Good afternoon, folks. My name is Keith Lamb, and welcome to today's Ask an Expert panel discussion. Today's topic is how to read a research article. As always, we will first just go around the room and introduce each other, ourselves. Tom?
My name is Thomas Prano. I'm a respiratory therapist here in Canada.
Brady?
Hey everybody, I'm also a respiratory therapist, not in Canada. I'm in Chicagoland. I'm at Rush University in Chicago.
Lee Wisdom?
Hello everybody, Lee Wisdom here from Kentucky, also a respiratory therapist. Thanks for having me.
Joel?
Hello everybody, Joel Brown from Delaware, respiratory therapist.
Delaware? Delaware.
Exactly.
I'm from Delaware also. So Kyle?
Yes, Kyle Mahan, Louisville, Kentucky. I'm a respiratory therapist.
Andy?
Hey everyone, Andy Klein. I'm a respiratory therapist. I also work in Chicago.
And Julie Jackson?
Sorry, I'm Julie Jackson, a respiratory therapist, and I live in Iowa.
All right, well, welcome, expert panelist. As always, we have a brief PowerPoint that we'll use sort of to guide our discussion. Tom will pull that up for us. So first up, we're going to talk a little bit about a description or the anatomy of a research paper or research article. I don't know if anybody wants to take the lead on this or you want me just to start. There's quite a few subtopics here. Of course, everybody that's on this call today and all of our expert panelists have both are active consumers of research articles and research papers, and also everybody on our expert panel have. Everyone has published their own individual research. So when you're taking a look at a research paper or research article, there are many types, and we'll go over the different sort of kinds of research projects. But every paper sort of has a combination and includes some of these different topics. Of course, there's an introduction and a title page, and some of the stuff that I looked at in preparation for today sort of demonstrates how to build a research paper. And this comes from an article that was published 20 years ago now by Rich Branson that shows the anatomy of a research paper, but from a perspective of somebody who's trying to write a research paper, not necessarily reading one. So introduction, title page, of course you have the authors and the author affiliations. Some of the common words that are used will show up in a keyword list so that everybody's aware of the specific definition of each word that the author is going to use throughout the paper. Usually there's one author that's sort of chosen as the corresponding author, and that's sort of is very sometimes that's a junior person, just so that if somebody's going to reach out and talk to somebody, it's that junior person that gets the experience and the interface. And then depending upon what kind of paper it is, and again, we'll sort of talk about the different kinds of research approaches. And depending upon what that approach is, there may be interventions or study procedures.
Yeah, and I'll just, before we go to the next slide, Keith, I'll just add that you sort of mentioned that a lot of the time there's corresponding authors, et cetera. That's whoever wants to be responsible for responding to feedback or messages. But also in terms of the layout of the article, when you look at the names of the authors, typically the first person listed is the one that probably did the bulk of the work with the study. Many first authors won't won't sort of announce that they did the study on their own. They're all very humble if they're a first author normally, because it takes a huge team of people. But one other thing to consider is that many times the last author isn't necessarily the one that did the least amount of work. Many times it's actually the senior author on the project. So it could be someone's supervisor. For example, if you work in a research lab, I'll give a perfect example. Almost everything we've published out of Toronto with Dr. Burchard's lab, the first author is the person that took the bulk of the workload, and then Dr. Laurent Burchard is the last author on the list, but it's because he's the senior author. He's sort of the one that made sure that the team was doing a quality research paper, etc. So sometimes looking at that senior author, you'll see similarities between the types of research that they publish. Many different first authors, and some might be the only paper you might see from that person because they did a research fellowship and then they moved on and maybe didn't continue to do that research. But the senior author you'll see pop up on many similar studies.
Yeah.
I'll add to. Go ahead, Joel.
Go ahead, Greg. I was about to say, yeah. And also, you will see, especially if you have someone who has a considerable amount of experience doing research, they may be carrying a large, a heavy load on the work, but they're really trying to promote someone, promote them, meaning getting them interested in doing research. So they will often use them as the first author, just to get their interest, right? Because sometimes you have that person that has that glimmer in their eye and they're really interested, but may not know all the details and may not know exactly what whatever the publisher is looking for. That person will do a lot of that work, but still put somebody as the first author.
Yep. I was just going to add that. So Keith, you mentioned that this paper that Branson wrote is 20 years old, but I refer to this paper all the time, and I literally refer to it when I'm writing my own papers. And so this is a little off script here. I don't even know that we have a script. Hold on. But Tom, I don't know if you can, if you have the ability to maybe share the screen, go to Respiratory Care Journal and show people where they can find this. I think this is probably one of the.
1 sec. Yep, I'll do that.
This is probably a paper that I have referenced the most in my entire career, in terms of when I do research, because I will always go to this paper to make sure that I'm literally getting the introduction anatomy correct in the 3 paragraphs that I'm using and those type of things. So if you can show that, I think that'd be helpful for everybody.
Yep.
Yeah, I agree. I immediately knew which paper I was going to go to.
Yeah. So if you go to respiratory care, you can Google respiratory care if you want, and then just type anatomy of a research paper. It was the first hit right here. And I'll put a link into the chat going directly to this page. I believe it probably requires you to be logged in. I think I've already unless it's a free download.
It should be free now. So if you just actually hit that PDF button.
Yeah, it should load it. But I might be logged in. Yeah, I'm logged in. That's why I wasn't sure. But here, let me log out and I'll go back to this page and just see if it still shows the PDF. Yep.
I think because of the age of the article,
exactly.
I think it's available.
Yeah.
But for anybody who's interested, I mean, this is a really good article, because what you see is even like on keywords. So if you scroll down, this says, I don't know if you can scroll down there.
Yep. Sorry, 1 second. I just pasted in the,
yeah. So it literally kind of goes through, the title, it's good. It tells you about the title, why it's good. The keywords, like for example, the keywords cannot be picked simply by the author's discretion. They should be terms that appear in the National Library of Medicine. So basically, these are the terms that are going to be how people find your article. And the corresponding art. It talk about corresponding author, even conflicts of interest, which is very important. I will tell you that when I read papers, I look at the conflict of interest. I just want to make sure that things are disclosed the way they should be.
Yeah, and it's important for everyone to know too that conflicts of interest are very common and don't necessarily discredit the author. Really, you need to look at what the conflict is and then what the subject of the paper is. And then when you read that with an open mind to say, does this sound biased towards this one product, for example, or this one device? And then you can sort of judge whether or not you feel that it's, maybe the person's talking about something because they've worked with that company or whatever. But it's very common to have, just so people know, if they see a conflict of interest, it's not something that automatically discredits the author. Perfect example, I already mentioned Dr. Laurent Bouchard. He has several because he works with industry to test their products in the research lab. So there's that relationship there. And usually these relationships are disclosed, whether they're financial or just, consultant.
It's somebody, I'm hearing an echo. You guys hear that? I feel like I'm hearing an echo except when Tom's talking. Maybe you, Tom. But as somebody told me once, it's not unethical to have a conflict of interest. It is only unethical to not disclose your conflict of interest. And that's generally how that works. Go ahead.
I think I've heard
Sorry, I
Nate
just
say
wanted
that
to
a
jump in
couple
and
of
let
times.
people know where this paper was at.
And basically that's where all these sections are coming from. I believe, Keith, you basically just highlighted the all of the sections that are discussed in that paper.
Yes, I did. If anybody has anything specific to sort of cover on this anatomy of a research paper, but Brady, Brady brought up really valid points about conflicts of interest and financial disclosures. It's very difficult, in my mind, and correct me if you guys have a different perception. It's difficult to not have a conflict of interest when you're really heavily involved in research. I mean, research costs money to do, and so somebody has to pay for that. Again, like Brady said, it's not unethical to have a conflict of interest, but you certainly need to put it out there so that people can make their own minds up regarding whether or not it's something important relative to the specific investigation that somebody's doing.
Yeah,
So go ahead.
I was going to say one of the things that are usually disclosed is they may say, for example, I'll use high flow nasal cannula as an example. Fisher and Paykel may have supplied the product, but it'll usually explicitly say something along the lines of they had no impact on the design of the study or the analysis of the data. So usually again, this is where it's extremely important to mention this because it's not, then it becomes more clear that this is not a Fisher and Paykel study, for example. They just said, oh, you want to study high flow? We're very passionate about our product. Let us supply the product, but how you use it, your protocol, et cetera, is usually up to the authors. They may have they may offer some advice on settings, et cetera. That's totally normal, which may help, but they don't usually, they're not usually involved in the actual setup of the methods. They may offer some advice, but generally it's explicitly stated that they had no bearing on the protocol and or specifically the analysis of the data. That's the big one, because of course, if you did a study and then hand over the data to the company that makes the product, who knows how many different analyses they're going to do until it finally shows that there's benefit, right? So you want to make sure that it's out of the hands of the people that are most likely to benefit from the results of the study if it's related to a specific product.
Well, I'd like to just chime in real quick too, talking about the anatomy of a paper. For the student or for the respiratory therapist who's getting into reading, we can't undervalue the importance of an abstract and a well-written abstract that can save the reader, the student. If a student's being assigned a paper where they're looking at high flow nasal cannula with COPD patients, there might be a ton of papers out there with pediatrics or neonates. So an abstract is a really great way to, what is it that I'm about to get into? Instead of having to read 12 pages, typically it's one paragraph, maybe two paragraphs. But the abstract is one of the most important papers for the reader, because it can save them hours of time, depending on the reason for them looking, getting into a scientific paper.
Yeah, I agree with you, Kyle. I would also caution people to not just read the abstract, because the abstract is really a commercial, right? It's a sort of an abbreviated, okay, here's our work in a condensed version. But and as we start talking about how to read a research article, I'm sure that everybody will have some commentary here. and some valuable advice. But just reading the conclusion in an abstract and then sort of taking that and trying to apply it is a mistake, and that you really need to be familiar with all of the content of a paper. We didn't mention it, but the statistical analysis and how that was approached, and what are the chances that that the data we came up with are really chance and not have anything to do with the intervention or whatever it is that you're studying. And so it's really important to read the paper. So I would call, although I agree with you that, and I'm guilty of it. Every paper I read several papers, a week, and I always look at the conclusion first because I'm not somebody who likes to wait for things, and so like most people on this panel. And so I look at the conclusion and I'm like, well, man, I either believe that or I don't believe it. And then I gotta go look at the paper to decide whether or not I really believe what the authors came up with or I don't.
Keith, I totally disagree with you saying we all read the conclusion. No, I'm joking. No, absolutely. No, it is that. And it is a habit that can be tough to break. And to go to the abstract and then go to the conclusion and then you're done. But I can tell you, and I know most of you guys here have all evaluated even the abstracts for open forum. I think when I first start doing that, that's when I learned the most that the conclusion, especially the conclusion in abstract, does not always make a good paper. So you really, really have to go back. And most of the time it's folks who are fairly junior in their writing of research, so they don't know that yet. And I always make sure I take the time out to write some really detailed information back. But yeah, it is, I mean, like you, I like to see the conclusion, but I know that the methods are going to be the thing that really tells me, and then how they put together their results, according to the methods that lead to a conclusion is the most important.
Yes.
I'm going to chime in too. One of the sections I actually like to read, and I don't always jump to the conclusion, but I have been guilty of that in the past. But I like to read the limitations as well, because the limitations often spark me to think about potential other research ideas for future. Even if the author doesn't say that they have another potential, sometimes it helps me to think about, okay, this was a limitation that they had. Is there a potential research opportunity here for us to look at that limitation differently? So that is a section that I actually do like to read. Plus, I also like to read that section to understand why maybe their outcomes were the way they were because of a particular limitation. So that's actually, not gonna lie, that's actually one of my favorite sections to read, just because I'm always looking for another opportunity to do another level of research or something like that. So I'm just throwing that out there.
I'm going to put my educator hat on for a second and say that for anybody who joined us today, I see some names that are, I see some people that I know on the comment list and probably more qualified to make this comment than me. But if anybody joined this because you really are wanting to get more involved in peer-reviewed research, and this is kind of your start, starting with that paper that we linked, which is driving this conversation, the paper by Rich Branson, you can take a look at that. And what it really demonstrates to you is that scientific papers actually have an order to them on purpose, right? So the section that you see in a paper are actually built that way for you to be able to read. It's almost I guess you would call it a systematic way, right? Like the introduction is, there's a purpose to the first paragraph. The second paragraph, like the third paragraph in the introduction, actually has a purpose. And then you go through the methodology, which I think the methodology for a lot of us was probably, including the statistical analysis, was probably one of the more difficult aspects of learning how to read research, because sometimes it's a bit heavy to get through these, and it's intimidating if you haven't done it before. And then, then you get things like the discussion. So the discussions in a scientific paper have a purpose. The authors are supposed to kind of address the discussion in a certain way to talk about, aspects of the paper. And then again, a lot of times in that discussion area, you'll see those limitations, which should make it clear of why this is. So the point of me saying this is for anybody who hasn't or haven't really, or feel intimidated by reading research or want to get better, starting with this, looking at this Branson paper that we're talking about, that again was written 20 years ago, is still relevant today. It will show you that these papers actually are by design, like they are written in a certain order for you to be able to read it. And I'm sure we're going to get to here later, Keith, but we talk about how like these journal conferences and stuff that ARC put on, when they do occasionally when they do the editor's choice. I think Julie, you've done them. I've done them. I'm sure probably everybody here has done some of those. But one of the things we do is we break down each section of the paper and specifically highlight it, and it becomes a way for you to better learn how to be a consumer. Back to you, Keith.
Back to me. Lots of questions. I'm just trying to jot down some questions that I want to ask you guys as we go along here. Anybody want to tackle these? So we know that there are different levels of research. We know that certain, anecdote is a sort of a level of evidence. It's a very low level of evidence, but it's still a level of evidence. And we know that the randomized control trial is probably the hallmark sort of way, if you're really trying to find an answer to a question, that our RCT is probably the hallmark, because you're controlling, the key word is that you're controlling for variables that you wouldn't be able to control for if you were doing a retrospective analysis, or even some of these systematic reviews where you look at a bunch of different papers that have the same theme, and you're trying to come up with a commonality amongst those papers that can be useful for clinical practice. And so the randomized control trial is probably the hallmark. Does anybody have any discussion want to discuss the sort of hierarchy of research? Any of our research or heavy researchers? I know that.
No, I think what you're saying makes sense, right? It's important for everybody here to know that there are different levels of evidence that we have to build our conclusions on, right? So these randomized control trials, essentially you take one big huge group and you compare them by, everybody gets the same thing except maybe one thing, and you see what happens at the end. So it's random and those things, but and then you got case studies, which are they're hypothesis induced, they're good for discussion, maybe give you some ideas of studies, case, all these things. So the quality of the evidence is there, and that's important when you read the study, because the conclusion may lead you to say, hey, this is the right thing to do, but you need to look at the quality of the study. And even in randomized control trials, you got to see how many people were compared in the groups, if it's actually even done the right way. So the quality of the study and the kind of study is important to draw good conclusions. Very important point.
And I think, as much as we know, and we would likely all agree, that systematic reviews and meta-analyses are at the top of this pyramid, I think most of us would also agree that it's like a blender. And if you want to put garbage in a blender and blend it up, you may end up with results that don't necessarily tell people what you are hoping they will tell. So the quality of the randomized control trials, or the research included in the systematic review and meta-analysis, is extremely important. And there's ways of reading meta-analyses and systematic reviews to be able to identify some of these issues, not necessarily with bad research, but when the methods for each of the included studies differ so greatly, you end up with something called heterogeneity. And when you have results that say, oh, it seems to favor this, but there's a heterogeneity, which usually shows up in a forest plot with an I-squared. If it's like 80%, you know that the data that was put in here was so drastically different that even though the data seems to lean a certain way, you can't come off with a solid conclusion on what that data is actually saying. So the funny thing with research papers is they'll use the words like may in the conclusions, like using this may lead to this. And they usually do that because they can't actually confidently say it does that, even though their forest plots seem to lean and support something. A perfect example is, VAP studies utilizing subglottic drainage tubes. When they put all the analyses together, they say, oh, it looks like it reduces VAP, but there's huge heterogeneity and other issues to be considered. But.
Yeah, right. And so all of that, Tom, that you just described, sort of is attempted to be teased out by doing a prospective controlled trial where you get rid of some of that hazy ambiguity that you're talking about. And so I think that's why what would be nice is if we could work harder on a standard approach to any randomized control trial, that any randomized control trial that's done in a specific area of interest was done, in a way that RCTs could be compared to each other and to be put in the blender without blending, if that makes sense.
Yeah, and this is the importance of understanding the methods behind the studies. Usually if I see a systematic review that has a data table with a lot of heterogeneity, I'm curious to know what were these major differences. And then as a clinician, you can look at these differences and say, yeah, there's no way this is a solid conclusion based on how different this is.
Right. You want to go to the next slide. I think this is where we can probably do it. Like each of us can individually sort of give our own approach to looking at a research paper. And these are sort of the questions that I ask myself whenever I look at a paper. And although I may predominantly go to the conclusion of the abstract first, then I go back and read the entire paper, and I don't always do it in one sitting. I put it down, I come back to it, but I sort of have a standard approach in terms of the questions that I'm asking myself as I read a paper, and whether or not ultimately whether or not this information is enough for me to get behind it and to teach it, or for it to change my practice. So the questions I ask myself is, when I read a paper, let's say I'm reading a paper about, gosh, I don't know. We all read so many papers. If I'm reading a paper about ARDS and mechanical power, what do I know about this so far? And I think there's a lot more that I don't know about it than there is that I do know about it. So is this paper going to add to my knowledge about that specific topic? What's the title of the paper? What is the sort of the author or the investigator's hypothesis, or statistically, what is the null hypothesis? What do I gain? What do I stand to gain from reading this information? And like many papers, they actually create more questions than they answer, right? And so does this paper generate another idea, or the limitations of this paper? Are there more ideas, like Julie referred to, that may be generated by the limits of this paper than are actually answered? And then I look at, what level of evidence is it? Is it a case report series? Is it a well thought out, designed randomized controlled trial? Is there a safety committee? Are there people that are responsible for stopping a trial before it hurts people? And what level of evidence? I like to use, for me personally, you all know I like to use smaller words. So I like to be able to describe something and for people to be able to understand it. So when I talk about statistics in general, meaning the statistical analysis of something, what level of evidence does that analysis provide to us? What's the strength of the evidence? How practical is it for me to take this information, this data, and then apply it at the bedside, or to apply it in the classroom, or teach or lecture about it? I like to use an example. If I'm doing a randomized controlled trial, and I like to use the oscillator data sort of as an example, because it was a really good example of this. If I'm doing a randomized controlled trial and I only have 4 patients, okay, and I randomize 2 of those patients to the oscillator and 2 of those patients to not the oscillator, and both patients in the oscillator arm of the trial die, I cannot use that low level of statistical relevance and then go on to say the oscillator has 100% mortality, right? It just doesn't make sense. There's too much chance involved in that. The statistical relevance isn't there for that. So I like to think about that and just sort of have an idea about that. And then ultimately, like I said, will the information I get from, and I think we should all be asking ourselves this, right? This is the advantage of being literature literate, is to be able to take that information and decide whether or not it's good enough information for you to get behind, or is it good enough information for you to teach and then apply it clinically, or is it not, or is it just sort of information that's hypothesis generating, like Brady said. Brady, do you have anything to add to that?
I think that the only thing I was thinking about this list before was kind of moving back, and I want to make sure before we go, we actually talk about Emily Lamarina's question there. I think that she's got something that we can discuss a little bit. Keith, I don't know if you saw it there.
Yeah.
But it's also kind of like, why read this in the first place? Like, what is the point? Like, what is the point of this? And I think we got to back up, and we're probably that's it. I mean, I think you're right. I think, what is this paper? What does it answer? How does it help me? What conclusions can I draw from it? I mean, all that stuff. I think you're right in what you're saying. But just to back up a little bit, I think we need to get more respiratory therapists even reading or consuming research in the first place. One of the things I would like to do today is I'm going to put a very shameless plug out here for Dr. Mahan and Dr. Wisdom's paper that I had the opportunity to be involved in. But we actually have a paper that's under review right now that helps people kind of walk through how to navigate peer-reviewed literature. And so it's under review, so we can't show it or anything. But, one of the things that we address in there is, why even do this? Why even read this in the first place? And I think that we need to get more respiratory therapists involved so we can get them to this point. If we're using the oscillator, and what did the Oscar trial and the Oscillate trial offer us, and was it good? Should we change our practice? I mean, for everybody in the audience to think about it, that are maybe experienced, think about in 2013, you had the Oscar trial, the Oscillate trial, and then you had the Proceva trial that changed everything we'd known about prone positioning, right? So we all had to look at those papers and the quality of those papers to start rethinking how we're taking care of patients with ARDS, right?
Yeah.
So it's a big deal.
I like, I had this slide in a talk just to add to the importance of why respiratory therapists should read research. This was a talk I gave in 2015. That's why the date ends there. But the red line is the year I graduated. And this is the number of publications on non-invasive ventilation from the time that I graduated to 2015. And you can see that if you stop your learning And again, you can, you go to conferences, etc., but you have to understand that the ability for you to understand what is current and relevant, you're either doing one of two things. You are relying on the people you work with to tell you what is best evidence, or you are learning it and keeping up to date on your own and ensuring that you are the patient advocate at the bedside. Because I can tell you, I've worked with physicians that aren't as up to date on this data related specifically to my role at the bedside than they might be. We do rely on physicians to be up to date, but think about how much information an average ICU physician has to be able to be up to date on. And that if you as a respiratory therapist are the one keeping yourself up to date with this graph, for example, you become much more of a patient advocate at the bedside and much more of an educator as well.
Thomas, I love that. And most people wonder why I have this IPPV machine I always have behind me. And I used to use it for that reason exactly. When I'd have someone come in and especially when my team, who I felt like they weren't staying up on what the latest research or weren't going to conferences, I would always point to it. And I mean, I'm fond of it. It was when I was in school back in the olden days, I had to learn how to take that thing and put it back together. But we used to use it a whole lot. And then later we found out there was like no evidence for it at all. Right. Like that we shouldn't be using it, at least not for what we used it for. We realized that wasn't it. So I always use it as an example. I also use it as an example for when I'd have, especially in my role where I was more with the physician group. So when they would come in with a new device, I'd always show them and go, "You see that thing right there?" And I go and explain yeah, this was like the best I used to walk around with it and give it, put it on a whole bunch of patients, and later we found that there wasn't a whole lot of evidence to support that. So go back and get your evidence, so I don't have another piece of equipment behind me. So that's literally why I have it. It's a talking point.
Yeah, and
you don't have this little brother that sniffs barometer.
Yeah. Yeah, exactly. And you know what? I think this is a good segue to two questions. So there's one by Emily and there's also one by Brooke that basically have the same sort of ideas. Like, what are some tools or suggestions for getting others interested in not only starting to read it, but also how do you teach them how to properly critically evaluate? And that's really a huge concern, is how to get people to properly critically appraise it. And actually, I did prepare a couple of example slides, Keith, for after we have this discussion, of papers where, because I'll just come out and say it, and I know we have some people that work with industry here, and they'll probably agree with me that a lot of the research that RTs learn about, if they're not actively seeking it out themselves by going to conferences or reading it themselves, is they're relying on the vendors that show up at the hospital to show them this new product, and then they provide them a paper. And of course, they're going to show you the part of the paper that seems to, if you can't read or understand research yourself, you're going to be like, oh, wow, that's fantastic. And I have two excellent examples of this that I'll share after this conversation. But it's one thing to just understand that when we where are we getting our information from? And most of the time it's from the vendors. And of course, if you can't acknowledge that there's a bias there, and the vendor themselves should acknowledge that. They could say obviously I work for the company, but this is a really well done study. But sometimes they give you a study it might be a well-performed study, but the evidence doesn't actually, or the data doesn't suggest what they're suggesting to you. And I have some good examples of that. But part of the things that I think we can probably agree on in terms of strategies for getting people used to it, attending conferences is probably the one thing you can do. Now, that's not probably the most cost-effective for an entire department, but I would add that, let's say your department has the ability to send 2 or 3 staff to a conference. I would then say, okay, when you return from this conference, we want to set up some days where you can provide or present to us some of the information you learned at this conference. So have a guided approach for sharing that knowledge with others. But I do agree this is a challenge for getting people excited to do it. But then the second step is how to properly critically evaluate. And that's where I think reading papers that are published in respiratory care really help. Like, for example, the anatomy of a paper. When it comes to actual data, like what do these numbers mean and these analyses mean? There's a recent paper published this year by Dean Hess in Respiratory Care that has them explaining what all of these numbers mean, what does a p-value mean, et cetera.
And I would like to just chime in real quick. I apologize. As soon as Brady said my name, the volume went out and I had to log back in and stuff. But I think one of the things too, and Brady had talked about that there was a paper written that's right now under review, but I think approaching like the discussion of how to read a paper, who is the audience of that? One, it's probably students who are just now learning what peak flow is and what an IE ratio is. And so oftentimes what's intimidating is that paper is written at an expert, right? It needs to be succinct and very detail oriented for hopes of replication or whatever, but it needs to be very, very technical to a certain degree and accurate instead of just using slang terms or terminology that maybe the novice student may be able to understand. But also, the question there about getting staff interested in is there's probably many RTs who haven't taken a stats class ever, or there's many RTs who haven't been in a classroom in 20 years. And so the idea of grabbing a respiratory care journal or any other scientific journal, and then they see whisker plots and they see, different, regression analysis, that can be very, very intimidating. And I'm not going to understand this and throw it away. Well, if it's either don't read the article at all or skip the statistical analysis section with all the numbers and stuff, then skip it would be my suggestion, and look at the discussion and look at the conclusion section where it may break it down and say, well, what we didn't work or what we did work. So even reading part of it, there may be some areas, and hell, even myself, even though I did quantitative research and I had to use SPSS and pivot tables and stuff, I am by no means an expert in statistical analysis. And so, maybe your education coordinator at a hospital, pick a topic of a month, pick an article of a month, and then maybe PDF it and highlight some of the areas and just get the staff reading a few sentences. And then maybe a little discussion, just build on that. But it can be very intimidating to read a peer-reviewed paper. But I think if you it's like a muscle. If you just start out a little bit, over time, the department can get more and more comfortable looking at, a complex paper.
I just want to add, first of all, I'm having a little bit of a moment here. I got 3 students on the comment board, Sarah, Emily, and Brooke. All 3 are my former students, and I'm having a proud teacher moment, and all 3 of them smarter than me, so I think I should be listening to them. But to address, I think Brooke and Emily had similar questions. I think one of the most important things to do is exactly what Andy Klein, who's on this call, put on my calendar today, and that's an upcoming journal club. And I think I saw Julie post about that as well. So I think probably at any level department, and Julie, I think you've done this in yours, we've done it in the 2 departments that I've worked in. Any level, you can either invite a person in now virtually, because virtual is easy, but invite somebody in and then literally sit around a table or have a discussion about each aspect of the paper, and let somebody who might have some expertise in their research talk about, again, like what Julie said, the limitations of the paper, can we do with this information. And, you could do a monthly journal club. Some people don't want to do things off work or in work, or you can't get away from the ICU. I used a model in my former institution where some of us, not all of us, some people had no interest, but a whole lot of us used to go to a restaurant, and at this one restaurant would give us a back room, and we would have like a departmental, we would do a journal club and usually plan it for like a basketball night or something. And we would do the whole first hour. We would sit in a room, and we would invite researchers that we knew to present their own work. And it would help us understand why they designed their study that way, why did they go about their analysis that way. But it was worked as a way for a lot of us to learn research, but it also learned it was team building in a certain way. And I feel like, Julie, you've done something like that too, right? You've done something outside of the hospital.
Yeah, we started ours outside the hospital. We actually started it in people's homes. There were a group of us that wanted to do it. So what we did is, this sounds really bad, I know, but it was kind of a food and drink fest. And then we would review papers. So it was team building. initially as well. And then, we would have a kind of a theme of what kind of food. Maybe it was Mexican night or Italian night or whatever, right? And then everyone would kind of sit around and we would choose a paper, and everyone would have that paper ahead of time, and we would review it, and we would literally, just as you mentioned, break it down. That's actually how we also kind of decided to start our research committee and had our research committee, and Keith was part of this process with us as well. To take a look at what papers were out there. The thing about our particular journal club that I can say I'm super proud of is how it grew and how it continued even during COVID, which was really super important because we were able to move it online, and we were able to actually take a look at some of the critical things that were actually being published in the early days of COVID to like really get it out there to everybody within the state. It is now like a statewide one, and there's lots of RTs that join it. Anybody can really join it if you just have the connection to get on it. But the thing I also love about it now, it has become multidisciplinary. So they now also have like pharmacy people that will present. So if there's like a new drug, for example, that's coming to the market, we all get hit by the pharmaceutical people. And much like the industry people, and I'm industry, so I can speak to this, the pharmaceutical people are also going to tell you specifically what they want you to hear, right? So oftentimes what we would do is we would actually ask our PharmDs to come in and present about that particular topic or break down the paper that might be represented around that topic. We've done that with PT. We've done that with OT. We've done it with lots of different disciplines, physicians, RTs. So I think it is a segue to get people looking and thinking about research. But to Tom's point, you do need to make sure at least one person in that group understands how research is written. Otherwise, I don't know anybody's going to gain a lot of knowledge from it, but I think if you have at least that one person that can help kind of guide it or keep it on track, should it get off track, I think that's helpful. So anyway, that's just, and I know that there are some other ones. I know I'm talking about the Unity Point one, but Brady's brought it up. I know the Pennsylvania Society for Respiratory Care was doing a monthly virtual one as well, where they would take a paper and review it with some researchers out of the Pennsylvania area. So I think there are probably more out there that we just don't all know about, but and obviously the ARC does kind of their journal cast where they're looking at a particular paper and topic as well. So I think there's a lot out there. And I don't know. That's just my point there.
And also, I feel like I'm talking too much, and I apologize. But everybody who knows me know that I always talk too much. I want to point out that Respiratory Care Journal staff and like Rich Branson, Jay Lee, Andy Miller, and others, Dean Hess, they've written, I think, Tom, am I right? An additional 13 papers, I think, recently on helping people be consumers of the literature. Dean has a paper like Research and Publication Respiratory Care, Getting Started in Research by Andy Miller, Denise Willis, Formulating a Research Question and Framing a Hypothesis, Submitting a Manuscript for Scientific Journal, the Overview of Survey Research, Conducting a Meta-Analysis. So literally the journal, for those of you that are involved or have an access to Respiratory Care Journal, you can go find, I think, at least 13 or 14 of these papers of that will kind of walk you through the process of being of writing the papers, but also I think this helps you understand how these papers are being written. And to address somebody's asked a minute ago about like how do you become a better writer, that's a great question. I think my opinion, the most important way to be a good scientific writer is to be an avid scientific reader. You have to read
100%.
1,000 of those papers to understand how they are supposed to sound. And once you start getting into, once you read enough of those as you're writing it, you know it doesn't sound like the 1,000 other papers that you've read.
I 100% agree with that.
Go ahead, Tom. Sorry.
That was it.
Oh, I was just going to add too. I think it's once you do write your first paper, I think it's super helpful when you get your comments back and be able to like I don't know. Every time I've written a paper and gotten the comments back, that's helped me for the next paper, not just this paper, but thinking about how I'm going to construct that next paper as well. So I think that's helpful, for at least it has been for me.
I just wanted to add something to this discussion about how you get people more able to digest research. And Julie, I want to say too, I totally agree with your comment, especially when you're submitting it to mentors like the ones on this call. They are not shy with the helpful feedback in terms of how to get better at whatever you're trying to do. Brady's laughing because he knows I'm talking to him. But what I wanted to add is we recognize this gap that you all speak of, Emily and Brooke and whoever else was having this thought, in that people like myself, Brady, I know some other people went through an associate's level program when they got their initial respiratory therapy education. And I can tell you that my own program and most of the ones I know of don't spend any time really introducing the student to literature, where to find it, how to read it, any of those things, because they're trying to teach them IE ratios and Venturi mask, Venturi ratios and all those things that they have to know to pass their boards. And so it doesn't leave a lot of time to talk about research. So I started teaching a class a few years back at the local associates program here in Chicago. And one of the things that I spoke to the people that run the program about that I'd like to do with my class is to introduce them to research. Now, it is a 30,000 foot view that I introduce them to, but by the time they're done with my class, they have an understanding that has removed some of the fear that you guys spoke of earlier. The, oh God, I'm not going to understand the statistics, or oh God, I'm not going to understand what they mean by these words. We just kind of take them apart, and I even give them a couple assignments to do almost like a book report on a article of their choice. And then we break them apart. We have a whole class period once they've turned them in where we break them apart and say, okay, what did you like about this paper? Where did you get that from? And then we find little pieces to take away. So by the end of it, they couldn't do research based on that, but they aren't afraid to look at a paper and read it and say, oh, okay, I kind of know what that means now. And then you get into what y'all were talking about, where you just read 1,000 of them, and pretty soon, little by little, it makes more sense, and you start having more conversations confidently about what you're reading. So I think that's an interesting place to start with some of those programs, is to get people, even if it's guest speakers like you guys on the call, to come and just do one class period and say, look, let's take a look at a couple papers and how they're put together, and take away some of the stigma here. So that's my thought.
I'd love to give a couple of examples here if you guys are willing to bear with me here. I've one is a personal favorite of mine. I mean, not the mode, but I'm sure. So let me just back up a bit. I would say in about 2004, I was a huge advocate for airway pressure release ventilation based on a few talks that I had received from people that had definite bias with this mode. And so one of the most, I would say, quoted papers related to airway pressure release ventilation is this one here: long-term effects of spontaneous breathing during ventilatory support in patients with acute lung injury. And this is the Putenson study.
We're not seeing it, Tom. Are you showing it?
Hold on. No, I know what I'm doing wrong here. 1 second. There we go. All right. So this paper here is probably one of the most referenced papers when people say that APRV requires less sedation to use. This is probably one of the most common references. This was a study in 30 patients with multiple trauma that were randomly assigned. Now, again, this doesn't necessarily mean it's a randomized controlled trial. This is important to understand how sometimes the word randomly assigned, people think, oh, this is a randomized controlled trial. There's no control here, because as you can see, they were randomly assigned to either breathe spontaneously with APRV or to receive pressure-controlled, time-cycled mechanical ventilation for 72 hours, followed by weaning with APRV. So basically, after 72 hours, they were switched to APRV, and then both groups were identical after 72 hours. And I'll highlight just for a moment this study here in terms of the settings. The P high was the same as the control group. The P low was the same as the PEEP in the control group. The T high was the same as the control group, and they allowed flow, like expirations, all the way to 0. Basically, the settings were identical, but one was APRV and one was pressure control, and the settings were identical in terms of the pressures reached, etc. So when people are quoting this, they're also not considering the way that it's used mostly in North America, which is more of the TCAV method, but it's still highly referenced as a reason why you should use the mode, because there's less sedation. But let's just quickly look at some important points here. First, if you jumped right down to the last part of the abstract here, which is essentially the conclusion, these findings indicate that maintaining spontaneous breathing during APRV requires less sedation and improved cardiopulmonary function, presumably by recruiting non-ventilated lung units requiring a shorter duration of ventilatory support and ICU stay. And this was, again, a study that was pushed by this person that was presenting APRV to me years ago, so I got excited. But let's just scroll down to some of the methods, and this is why it's extremely important to understand the methods. So in the APRV group, all patients maintained spontaneous breathing, and they had sufentanil and midazolam adjusted to basically to achieve a RAS score, or an RSS score, as mentioned here, of 3. And then to assess cardiopulmonary function during APRV in the absence of spontaneous breathing, they gave patients in the pressure-controlled group sedation to get a RSS of 5 to 6 and paralyze them for 72 hours. So if you're going to paralyze a patient, you darn well better be sedating them well, because that would just be torture. So here we have a study where for 72 hours, they were managed on a pressure control mode with the same settings as APRV, but they were paralyzed for 72 hours. And most people were, again, reading the study and saying, oh, you need less sedation and you have less time on the ventilator. But all you did is give the patients a 3-day, or essentially a 72-hour head start. And you can see here that after the 72 hours, the patients in the pressure control group were then, they had their sedation reduced for a RAS of 3 to allow spontaneous breathing on APRV. So again, that's just one example, but the next example is probably, these ones are more of my favorite here. This one here was a paper provided to me. Now we're just going to look at the top here, the table 2 first. This paper was brought to me by a company that sold subglottic drainage tubes. When the study was published in 2010, he booked an appointment, came into my office, and he handed me this paper and he goes, why aren't you guys buying the subglottic drainage tubes? He goes, look at this, reduction in VAP. So if you look, the SSD is the subglottic secretion drainage, the control group, etc. You can see all across the board up here, there's significant differences in VAP and the incidence of VAP, early onset, late, etc. And then the prior duration of mechanical ventilation, that's fine that it's not different. That's important that both patients were similarly ventilated prior to the study. And me being someone who reads a lot of research, one of the questions I asked them immediately was, where am I saving my money? And he said, what do you mean? You're reducing VAP by 50%. What do you mean? How are you saving your money? And I said, did you read the secondary outcomes table? And of course, the person had not read the secondary outcomes table. And you can see tracheostomy, duration of mechanical ventilation, length of ICU stay, ICU deaths, hospital deaths. There was absolutely no difference between these groups. So despite reducing an infection by a significant amount, there seemed to be no difference in other clinical outcomes. So either there's a problem with diagnosing VAP properly, or these tubes clearly don't provide the outcomes that we were assuming actually would cause a reduction in cost by using these tubes with all patients. So, oh, and then we'll comment this. I'll get to this comment down there. Someone disagrees with my APRV thing. This will be fun. Okay, let's talk about other limitations. Here's a study. This was a graph that was shared highly by a company that sells something that they call high velocity nasal insufflation. I won't say a name directly, but it's not Fisher and Paykel. High velocity nasal insufflation, and they show you this paper and they say, look at the significant reduction in intubation. This is for all comers in an emerge department, and they show that non-invasive ventilation patients had higher intubation rates than the high velocity. However, this is what's called intention to treat, which means you just take the groups for what they were randomly assigned to and you report their outcomes. And there were less intubations in this group, but guess what? There were more failures in that group and they were rescued with BiPAP. So without non-invasive ventilation, the high velocity nasal insufflation group would have had higher intubations, but they were rescued by non-invasive ventilation. This is called a crossover. But when you do the intention to treat analysis, you don't you don't include the crossover patients in the other group. That would be bad statistics for many people, because if they were sicker and they ended up dying in the other group, it would make the other group look worse. So it's important to understand that if someone says, hey, look at the significant reduction in intubation, that you understand that, okay, but I'm not getting rid of my BiPAP machines because most of the patients required rescue with non-invasive ventilation. And then let's just throw this up here so I can read it. If you can emphasize individualization to assess pulmonary mechanics, ventilator waveforms, lung disease process is vital. If APRV, TCAV will be used, or any mode as well can cause injury, the competency is not there. So I'm not sure this comment, in terms of the purpose of me bringing up that previous paper, is that if you just read that APRV requires less sedation, in that paper, that was their conclusion. They increased sedation and paralyzed patients for 72 hours. And then after that 72 hours, treated the patients identical in both groups. So if you disagree that that's a misinterpretation of that study, I would disagree with that comment, because that's exactly what the issue is with that paper. I didn't say much of anything about APRV TCAV, aside from I definitely said that their mode, the methods in that paper aren't even close to TCAV. So, but people that write TCAV related papers, at least historically, were quoting that paper a lot. That's actually how I found that paper, was through a presentation of someone teaching more of the TCAV method, and they referenced that Putenson paper. So this is the issue when you read papers. Make sure you realize who they're referencing and what the methods were before we draw conclusions.
Yeah, I think Pablo is actually agreeing with you.
And then Keith, Tom, real quick.
Oh, sorry. I guess I misunderstood that question, because it just says I disagree with that article. Okay, I do disagree with that article as well. If you emphasize the individualizing, anyways, I misunderstood that question, I guess.
Yeah. What were you saying, Andy?
I was just going to ask you guys to talk for 30 seconds or so on the difference between the articles we're discussing here and a quote-unquote white paper. Because I think that's something that confuses some people when they are presented with that quote unquote data.
I can start on that one if you want. A lot of white papers are essentially, most of them, there is definitely a conflict of interest, because the white papers are typically sponsored and or published by a company. So they may have provided the data, they may have suggested the protocol. They may not have, it's possible. But the white papers are essentially like short reports or short studies that were specifically designed to highlight a specific feature of a manufacturer's device. And they usually report these white papers. I even wrote a white paper for a company once, and the white paper was just a review of the literature. Actually, it was like a systematic review without a formal systematic review. It was just, this is what the data says on this subject and this subject. So white papers are generally sponsored articles. I would say someone can disagree or add more comments to that, but I feel like they're mostly designed to highlight a feature or practice with a specific device, and then they're usually sponsored by companies.
Indeed. All right. So did we get to all the questions that were sort of being asked? I never got a chance to reply to the whole, I'm a big believer in journal clubs. I'm a big believer in doing what we're doing right here. And if you look at our I think it was Caleb who mentioned, be nice to have a place to put all these papers. If you go to our website that's listed here, www.inspire-rt.com, and go to the resources section, we have a bunch of categories for different papers, mostly PubMed links, as to not sort of infringe on any copyright stuff. But and if you have a paper, anybody out there that has a paper they think that should be listed, it's just us putting them up there. So send them to me, and I'll certainly take care of that. I want to thank our panelists for today. I want to thank our participants. I want to thank you for your questions. We will be getting back to everybody. If you go to our website and you sign up for the notifications, then when we have our next topic decided, you'll be the first to hear about that. Otherwise, follow me on LinkedIn, and stay tuned for our next month's topic.
Have we decided the next month's topic yet?
No, we have not.
Oh, well, if people have some requests, maybe we'll wait 2
Yep.
minutes and see if people type anything in. And sorry again, Pablo, for misunderstanding the the comment there. I realize now we're probably on the same page with at least with that paper. It was just it was a wordy question. I didn't quite comprehend it all before I commented on it.
All right. If you do have recommendations, then you can just go to the website. We have a template there. You just click on it and put your recommendation in.
Ah, yes, you have an online form there. That's right. I
Yep.
remember.
So, all right.
Okay,
guys.
thank you all for attending as well.
Thank you so much. We will put this. This will be the recording will be available so that if you want to use this in your teaching or just revisit it, then it's available.
And Keith, you said you're going to post some of those articles, correct?
Yeah, I'll have to. Yeah, you'll have to send me the titles, and then I can.
Yeah, I think Brady said he was going to send them to you in Madison.
Yeah, if somebody sends me a title, then I can PubMed search it and put a link to it.
Awesome. Okay.
All right. Thank you, everybody. Have a good
Bye-bye.
afternoon.